Okay, since we are running little late, I'll take 30 to 35 minutes instead of 40 minutes. If that is, we will stop at 2:05. So I understand Dr. Bhavesh Parekh. Is he there?
Yes, absolutely. Amish or Bhavesh mein aave.
Dr. Amol, I could see his chat. So he is
Yes,
there.
I'm there.
Can you please on all of you your cameras? So we really want to see all the discussants.
Correct.
For a very, very live discussion, Amish is on.
Dr. Lalit Mohan Sharma. Is he there? Dr. Arvind Kumar?
Yes, sir.
Okay, perfect. And Dr. Shivakumar Thiagarajan?
Yeah, hi, I'm there. Good afternoon all.
Right. Dr. Shivakumar, I understand you are the only surgeon amongst all of us.
Yeah, that's right.
Okay, perfect. That's why I was also waiting for Dr. Anil De Cruz. Thank you, Dr. Jyoti. I honestly didn't understand what all can we cover in this. So we try to do the best we can. Since Dr. De Cruz is not there, the important point is about today's topic is challenges. So challenges in rare head and neck cancer. So what I understood, there are the few challenges in rare head and neck cancer is late or incorrect diagnosis, limited number of experts in the field, limited number of clinical studies. In fact, when I was reading for it, I could hardly find any phase 3 studies. Less registered medication, FDA approved, category 1, very, very difficult to find. Limited number of guidelines. Where do we have guidelines for salivary gland tumors? Where do we have guidelines for secretory carcinoma? And there are very limited registries and biobank. So Dr. Shivakumar, let me start with you. Since you see these rare head and neck cancer first, do you think that there are any other challenges apart from this in rare head and neck cancer?
The other thing is, first of all, the diagnosis itself, because as it is, they are rare, and to have a consensus as to what are the, the points in favor of these. That's the first
point which I have written, yeah.
Yeah, so that is one, yes. And of course, I think you've covered most of the points. I think the first challenge, just to reiterate, is in the diagnosis, and then to frame and to plan the treatment for these patients, because as you rightly have pointed out, there's no clear-cut guidelines. But just the one point that salivary gland tumors cannot be really considered as rare, because the only point here is you have a plethora of histopathological diagnosis.
Yeah, 22 different histopathologies. So each salivary gland tumor itself will become a rare. So I get your point. Can I invite Dr. Jyoti here? Jyoti, I know you are not supposed to speak in this panel, but can I request you, am I missing some point here?
I was trying to reach to Dr. De Cruz. So what did you ask, Amish?
Jyoti, the challenges which I have written here in rare head and neck cancer, do you think that anything which we are missing?
No, I think you really enumerated very well. So please.
Amish, as far as the definition of rare cancer is there.
I'm coming to that, sir.
Yeah.
So, Bhavesh bhai, you be there. Say Dr. Anil, Dr. Shivakumar or Dr. Anil De Cruz calls you one fine morning and says that, Dr. Bhavesh, I am sending across a 44-year-old male with secretory carcinoma of minor salivary gland, and it is metastatic. What is your first thought process when you get such a phone call?
First, most important part is that as a medical oncologist and the surgeon is sending me and it is a metastatic, then my point is whether the histology or whether the IHC or whether any molecular marker has been done or not, or whether I should talk with my pathologist, and is there any
patient has still not come to you, Bhavesh bhai.
Okay.
My point of asking this question is that when such rare histology comes, do you start reading immediately, or do you wait for the patient to come and then start reading? That is the question.
I will read first rather than come. Yeah.
Dr. Arvind, you are laughing. So let me ask you, what do you do in such scenarios?
Yes, sir. The moment I get a call, I open the NCCN guidelines for that.
You open the NCCN guidelines for that. So, that's Dr. Amol, you read the most amongst all of us. What do you do in such a rare histology when the phone call comes? You first see the patient and then read, or first you revise?
So we will try to first see the patient, but of course, nobody likes to treat the rare cancers. Everybody likes to treat the common cancers.
Correct,
So
correct.
if a rare cancer is coming to you, of course, everybody has to read.
Agreed. I put this point because, when such a patient comes to me or phone call comes to me, first thing I do is open the book and start reading about it, because you don't want to see naive. And these are so rare that, you have to read about that. So definition, Dr. Shiva Kumar, definition of rare head and neck cancer.
Well, I think you've given the numbers for it. I think it's in terms of per lakh patient, that how often do you see them? That is one definition. And I mean, just to put it in simple terms, it's the cancer that you don't see often, and so that is the definition I would look at.
Definition. Dr. Bhavesh, you were mentioning about the some answer. Do you know any definition of rare head and neck cancer or rare?
As when there is a call from Shiva Kumar, as when there is a moderation by Amish Vora, we have to read something. So when I reading the definition, all the point you had included, only one another point that mention is the prevention also. The prevention of rare cancer is little bit also difficult. Correct. So not only diagnosis or not only research or not only the other part, the prevention of the rare cancer is also difficult. So as Shiva Kumar told, mostly we all are like number 6 per 1 lakh population per year. That might be or less than 15 per lakh population, and that is a ESMO definition. But again, like we in India, what I feel that mostly as head and neck cancer, we can have salivary gland tumor or nasopharyngeal cancer or minor salivary gland tumor. That is a rare cancer as a medical oncologist of 25 years of practice.
You are absolutely bang on, Dr. Bhavesh. And this is an ESMO and Astro definition, that incidence of less than 6 in 1 lakh is the one. And this is also sort of, supported by this union, and there is a consensus on the same. Why?
Can I just add one point
Yes,
in terms
Dr.
of rare? Yeah. So the rare diagnosis, like for example, in India, the nasopharyngeal cancers, like what was mentioned, or even salivary gland tumors might be less. But in certain geographic locations, some of the commonest malignancies. So I think the geographic location also has to be taken.
The point very well taken, Dr. Shiva Kumar. Correct. Dr. Amol, why should this be discussed? And I'll put forth, since the conference is running late on time. The survival has not changed in the last 20 years. You can see on the screen. And Dr. Amol, do you agree on this point? And this is what your thought process is also?
Yes, I do agree, because of course these cancers are rare and we get very few cases across in our clinical practice, especially if we are not in an academic institute. So it is necessary to discuss these tumors, and it is always good to have a multidisciplinary team discussing the tumors before we treat them, so as to improve the survival.
Correct. So the survival has not improved in last 20 years at all, if you see, as compared to common cancers. And, we have covered this. So I am going to go beyond that. These rare cancers are salivary gland tumors, because of there are 22 different histologies itself. So rare of rare, epithelial tumors of nasal cavity and sinuses, Merkel cell carcinoma, soft tissue sarcoma, lymphoma. And this is the very good chapter which I read, and I think everyone should read about this. There's a very nice thing, and they have included based on incidence wise that why these are called as rare tumor. So Dr. Shiva Kumar, what is your thought process in the question which I have put forth?
So the question is whether I agree salivary gland tumors are rare. Is that
correct? Correct. That the 22 different histopathologies are there. So this is, the incidence, as you pointed out. I just wanted certain questions, because then I thought that let me put the answers and see, are these matching in your clinical practice, Dr. Shiva Kumar? So let's start from the first. Incidence in head and neck cancer is 6.5%. Agree or disagree?
Yes, I do agree.
71% would develop metastatic disease as a natural history.
Not all. Maybe adenoid cystics, because they tend to survive for long. Mucoepidermoid might do. I mean, they do not develop distant metastasis. Salivary duct carcinoma, they would present with distant metastasis, and even if they don't, in a short course of time, they would develop. So it depends on the histopathology that you're dealing with. So these are some of the common ones: adenocarcinoma, acinic cell, and all that. Among the minor salivary, among the salivary gland.
You have talked about the survival. We'll skip the 2 questions. Worst prognosis is salivary duct carcinoma. Overall survival hardly 5 months on best supportive care.
Without a doubt.
You would agree. What are the common salivary glands you see in your clinical practice?
So in my practice, I would see mucoepidermoid carcinoma, which is the most common. That's the most common salivary gland carcinoma that we would deal with. That is I would divide it into major and minor. So if I look at major, it is mucoepidermoid. If I look at minor, it probably will be adenoid cystic carcinoma. And of course, following mucoepidermoid will be adenoid cystic carcinoma, and then salivary duct carcinoma will be maybe 3rd or 4th down in the list.
So, Dr. Amol, I am sure we still don't have Dr. Lalit Mohan, right? And that's why I'm asking questions to these people.
Amish, I have joined. In fact, I'm sorry I'm a bit late.
No problem, no problem. Dr. Lalit, welcome. Let me ask you, mucoepidermoid carcinoma, every textbook mentions is the most common. Yes. If I go back to my practice, I have seen more of ACCs than MEC. Would you also agree with that experience?
Yes, I agree that ACC is more commonly seen in our clinical practice. And in addition to the previous discussion, I want to highlight that many patients we are seeing is locally recurrent. So like head neck carcinoma, they represent with the cutaneous metastasis rather than the distant metastasis. And we also keep discussing these tumors, and it looks that nothing has changed. What you rightly mentioned in your previous discussion, that probably NGS may guide us for NTRK or something like that, where we have some definitive treatment for that.
Okay, perfect. So, Dr. Bhavesh, do you agree that we see more of ACC as medical oncologists than MEC?
Yes, I agree.
Dr. Arvind? Arvind, you are unmuted.
I agree, sir. It's ACC what I see whatsoever.
What, Amol?
Yeah, I do agree. Whatever little that we see more ACC.
Right. That is what, maybe Dr. Shiva Kumar, you are not sending us more of MECs, and that's why we are seeing more of ACC.
I think it's probably because the number of ACC with lung mets who are probably symptomatic or who require some treatment will be more. So that's why we're sending those kind of tumors to you more than mucoepidermoid don't present with distant metastasis, which we tend to operate more. So,
right. You are right, but still the textbook mentions that 50 to 55% of mucoepidermoid ultimately develop metastasis.
That is
and I hardly remember. I can remember on the tip of tongue 3-4 patients of ACC, but I hardly remember any patients on MEC. That's why I asked this question. Probably we are seeing more of metastatic ACC then, and even the classification is ACC and non-ACC. We'll quickly go to that. So, we need to improve upon, so we need to understand disease better. And how do we understand? We don't have a histopathologist here. And so I'm not going to discuss IHC and histopathology. In terms of the treatment, let me ask again, Dr. Shiva Kumar, you are the only surgeon. What are the challenges in surgery? If you can quickly tell the audience so that they understand it. What are the 3-4 challenges in surgery in salivary gland tumors?
Salivary gland carcinoma, the major challenge is the facial nerve. So,
correct.
Preserving the functions of the facial nerve is the most important challenge when we operate upon salivary gland. So that is so if we can deal management of the facial nerve intraoperatively is the most important point actually. And there's nothing more to it. And the second thing is to do the neck dissection. When to do the neck dissection? Address the neck in a salivary gland carcinoma. These are the points mainly.
Dr. De Cruz has joined. I don't see. Yes. So
and the extent of neck dissection, I guess, when to address, and if you're going to address what levels of neck dissection you do, these are some of the controversial areas in a salivary gland tumors.
Dr. Amol, you are one of the most well-read medical oncologists. So I am going to ask this question to you. Any role of adjuvant radiotherapy in salivary gland tumors?
The role of adjuvant chemo in these cancers is rare because they are not greatly
Radiotherapy, Amol, not chemotherapy. I'm
Of course.
asking of radio.
No, the role of radiotherapy is very much there, and in the principles of treatment don't change whether it's a rare or common head and neck cancer. Surgery followed by local radiotherapy should be offered if it is indicated, and there is very much role of adjuvant radiotherapy in salivary gland tumors.
Salivary
The
gland
role of
tumor.
chemotherapy is limited.
Doubted. Dr. Bhavesh, adjuvant chemotherapy, have you given in 25 years of your practice in salivary gland tumor post-surgery?
No.
Dr. Lalit Mohan, have you given yourself
No.
chemotherapy in adjuvant setting?
Never.
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 I have also not been referred neither in Tata Hospital nor where I was working. Dr. Shiva Kumar, do you send patients for adjuvant chemotherapy after surgery right now?
No, only adjuvant radiotherapy. Yeah.
So the challenge amongst medical oncologists as far as adjuvant is over. Why I put radiotherapy? Because as Dr. Amol said, it is a crystal clear guidelines for adjuvant radiotherapy in NCCN. This is the first version of 2022. But I came across this is amazing National Cancer Database analysis, which is 2019. And if you see intermediate risk, low risk, everybody agrees there is no role of RT, but NCCN says you should give radiotherapy in intermediate risk also. But this database of 16 years of data, they said that only in high risk, and high risk is ECE positive and margin positive. They have taken out LVI, they have taken out PNI, they have taken out N plus also. So this is something can be a challenging in terms of the radiologist, but I would put it across for radiotherapy conference. This is what I feel it is going to be difficult. So let us discuss the, metastatic disease in next 10 to 15 minutes. Yes, next 15 minutes. This was Memorial Sloan Kettering Cancer Hospital 2013. They sequenced the genome of a rare head and neck cancer, and that was adenoid cystic carcinoma. I'm not going to go into the details of that. So, let's start with our surgeon, as always. Adenoid cystic carcinoma of salivary glands. What are the clinical features in your clinical practice you see? How do they present?
I mean, so they probably might tend to present with more incidence of facial nerve palsy at presentation, adenoid cystic compared to the rest of the salivary glands. And of course, in the final histopathology also, the involvement of the presence of perineal invasion is much higher in adenoid cystic. The other thing is adenoid cystic, they may present more often with lung mets, which are absolutely asymptomatic. There might be single or multiple lung mets, but they are asymptomatic. Even in which case, even if it is only pulmonary metastasis in adenoid cystic carcinoma, if there are no extra pulmonary metastasis, then we would still go ahead and offer surgery for that particular patient if it is adenoid cystic, not in other types of salivary gland carcinoma.
Right. So in addition to what Dr. Shiva said, what I came across is minor salivary gland is the most common area involved. 5th decade is the time when people present. 65% diagnosed with lung mets, as Dr. Shiva also said. Around 3 to 4 years is the median survival. Surgery was the only modality at that point of time. And Dr. Shiva Kumar actually mentioned that sometimes in a metastatic lung disease, if the patient is completely asymptomatic and if the progression is more than 1 year or 2 years, you may observe also these patients. So that is something which is as a guideline which is there. Dr. Bhavesh Bhai, 46-year-old patient, ACC of parotid gland, surgery done 3 years back, disease recurrence now in lungs, patient is symptomatic. IHC shows c-KIT expression. What would you do now? You have to unmute yourself.
Interestingly, this patient of a parotid gland or ACC of parotid gland and now metastasis, the IHC shows c-KIT expression, and there are some reports or some literature says that you can work imatinib in such type of metastatic parotid gland. So I think now gradually the more and more NGS or more and more molecular profiling will be helpful in such type of rare malignancy to be treated.
Would you would you send NGS first or would you start imatinib on this patient?
At present, I am starting with imatinib with IHC shows c-KIT expression.
IHC shows. Amol, would you agree on that point?
If the patient is symptomatic, I'm not so sure whether the imatinib will act that fast for a symptomatic improvement. I will start probably with a platinum-based doublet and wait for NGS and assess the response and then take a call later on whether to give imatinib, especially if the patient is not tolerating platinum-based doublet.
Right. So we have a difference of opinion. Lalit sir?
Yeah, I'll also agree, in fact, that since the patient is symptomatic, so we want to achieve faster response. So for that, again, platinum-based chemo will be the choice. And meanwhile, we can send the sample for the NGS study. And once the disease comes under control and the patient becomes symptomatically improved, then we put the patient on either imatinib or based on NGS.
Based on NGS. Dr. Arvind, you would
Can I
also
make a
do the
point
same?
here?
1 minute, Dr. Shivakumar. I'll
Yeah.
come to you. Yeah.
Yes,
Dr.
sir.
Arvind, you would agree on the same?
No, sir. If I have any targetable drug for that, I will go ahead with the imatinib because the response rate is it's better. It's not that it's minimal or the response rate is more than 50%. So I
Okay.
will.
Dr. Shivakumar, we have completely hung parliament.
Yeah,
You
so
wanted to
that
say
explains.
something.
Yeah, exactly. So just to make it even a bit more interesting, I will. There's
And
one
it's
other
not
point
a
that.
chemosensitive.
Sorry.
To add on, just a minute, sir. It's to add on. It's not a chemosensitive disease.
It is not a chemosensitive disease.
That's
Okay.
right. Yeah, so
Dr.
I think
Shivakumar?
that sets the stage for what I'm going to say right now is that as what the panelists have been saying, it's not chemosensitive. So sometimes the discussion that we have in the joint clinic is whether you need to offer, a metastatectomy if it is only restricted to the lung and if there are not multiple mets, oligometastatic adenoid cystic carcinoma. What is the role of metastatectomy? So that's the debate. So do you want to only treat the primary or do you want to also do a metastatectomy either in the same sitting or in a as a second sitting?
Dr. Shivakumar, point absolutely well taken. NCCN guidelines also mention that if you can remove metastasis, then metastatectomy can become one of the options. I agree on that point. Now, looks like, we all the panelists and myself, we are reading different books. I read that, let's once and for all talk about imatinib in adenoid cystic carcinoma. These are the various targets based on the NGS findings, what people have tried. And this is what the finding, you see the overall response. Imatinib, there are 0% response rate. And I will sort of, these are the two different papers. And both the papers have crystal clear said that imatinib does not work in adenoid cystic carcinoma. c-KIT is an expression. It is not probably the tumorigenesis mutation which is there. Probably it's a passenger mutation or it is just an expression. Remember, IHC gives just a protein expression. It does not talk about mutation so much. So we have to be very careful of what we are talking. And this is the chart, which is very beautifully in that chapter, which I showed. And you see the number of targets and the number of response rate, what we have got. So, what I have understood is ACC metastatic, unfortunately, even though response rate is 30 to 35%, we have to first start with chemotherapy. Or we have to put these patients on clinical trial, most likely a basket trial, which would be the best in these patients. That is what basically I would understand that. So conventional chemotherapy is the way to treat. Imatinib does not work. Immunotherapy does not work. Maybe lenvatinib. That is what category 2B it is said. And some trials have shown the overall survival better, not very good response rate. I am not bought on lenvatinib at all because it can be a toxic drug. I think we have to keep watching for the new space in this. So let's very quickly, 5 to 7 minutes, talk about salivary duct carcinoma. Now, Dr. Shivakumar, just in one answer, you would agree salivary duct carcinoma as a whole is a rare head and neck cancer, right?
Yes, I do agree on that.
And I would want your opinion. How do they present? Because we see only when metastasis is there.
Yeah, that's true. So they do present with, parotid swelling and sometimes with neck node. clinically palpable neck nodes is more often. So whenever we get a diagnosis of salivary duct carcinoma, we would minimum do a PET scan. That is the distant metastatic workup that we do, because quite often we do pick up distant metastasis. So, and then from there on, we make a decision for whether the patient goes for a surgical line of treatment or goes for a non-surgical treatment. So that's the way we go about it.
Okay. And which is the gland which you see the maximum in salivary duct?
Parotid. Most common is parotid.
Most common is parotid. And is it right that it is on the 6th or 7th decade of life, as it is mentioned here?
Yes. It's mostly in elderly patients, 50 plus.
Bhavesh bhai, have you seen salivary duct carcinoma in your practice?
Yes.
And what was the presentation?
Mostly patient come after the surgery, and mostly after 2 or 3 years, and mostly patient came from the head and neck cancer surgeons to treat once patient is metastatic.
Okay. So we have a metastasis patient, Dr. Lalit sir, 64-year-old male, submandibular swelling of short duration, tumor in the submedulla with neck nodes on the same side. Biopsy shows adenocarcinoma, NOS. PET CT shows liver mets. Biopsy of the liver met also was done, and the same. Salivary duct carcinoma presents as an adenocarcinoma, NOS also. How do you proceed? Do you start chemotherapy in these patients?
In fact, first we sort of review and reconfirm the biopsy, and then we do NGS and
so
start.
It happens as salivary duct carcinoma, and you have sent for NGS.
Right. So start with the doublet, in fact, platinum-based chemotherapy. I have seen 2 patients, in fact, whom this also did not work. One was 50 plus and other is 32 currently, in fact, on treatment.
Okay, so, understood. Dr. Amol.
Yes, sir.
Can you talk about novel targets to overcome treatment resistance in salivary gland carcinoma or salivary duct carcinoma?
There are few case reports in which they have tried anti-HER2 drugs and they have shown some benefit. But as an overall, there are no great targeted therapies available, but people have tried anti-HER2 drugs, especially if the HER2 pathway is significantly positive and driver pathway in NGS.
Okay.
Other than that, some people have tried immunotherapy drugs.
Immunotherapy drugs also. Bhavesh bhai?
I had recently one patient of salivary gland tumor, and patient is already received 17 Herceptin, as well as already received the Calutide also, as patient was androgen receptor positive. Unfortunately, patient responded very well to lung metastasis, but locoregionally, lymph node was not responded. So I have to refer to a radiation therapist for the axillary lymph node, and patient was excellently responded by the radiation oncologist.
Okay, excellent. Very good. This is what the literature says. Yes, Dr. Shivakumar, please go ahead.
There's just a recent publication in JCO, I think in this month itself, on abiraterone acetate in metastatic salivary duct carcinoma in patients who are androgen receptor positive. And they have reported good response to adding abiraterone acetate in such a group of patients.
Absolutely correct. Dr. Lalit, you would agree on what I have written here. This is the standard. I didn't know till I also read this that 80% are androgen receptor positive and 40 to 60% are HER2 positive. And sort of, do you think that you agree on this point, or are we not doing this in all patients?
Yeah, I think we don't do it in all patients, but recently one of my patients was also androgen receptor positive, and that was learning curve, but I did not know the figure of 80% and HER2 in...
Correct. Absolutely, so true. So, as Dr. Shivakumar said, I will, go through this. There's a complete androgen blockade in patients with AR positive tumors has been tried. And if you see the response and the clinical benefit ratio of 85%, the median OS of 30 months, remember 5 months with best supportive care. And in HER2 positive patients, there are phase 2 trials done, and there is a clinical benefit rate of 70% with median OS of 39 months. Well, right, if you don't treat anything 5 months, if you give chemotherapy around 14 to 15 months, and if you go by target treatment in these rare tumors, You alive the patient to be alive for 3 years and above. This was amazing. And ASCO oral paper 2019 has shown that patients who progressed on trastuzumab, they have treated with TDM1 like we do it in breast cancer. So 9 out of 10 responded with median duration of 12 months. And as Dr. Shiva Kumar said, those who progressed on complete androgen blockade, they respond to abiraterone acetate and enzalutamide. So I feel that all salivary duct carcinoma should be tested for androgen receptor and HER2/neu, and you cannot miss this. This is something which is very, very crystal clear. We are running short of time. So, Dr. Shiva Kumar, secretory carcinoma, you have to highlight what do you see in your clinical practice?
So this again is more or less the presentation is similar to the salivary duct carcinoma, and I would also rate it like a high-grade tumor, very much similar to a salivary duct carcinoma. Just that the expression of these the androgen receptor, but it's more or less as aggressive as the salivary duct carcinoma.
As aggressive as salivary duct carcinoma. Okay. Probably Dr. Shiva Kumar, you must be right. I don't remember secretory carcinoma because earlier it used to called as MASC. So, it is difficult for me. But what the guidelines say, the textbooks say that, it is the survival is the longest in terms of secretory carcinoma as compared to other salivary duct carcinoma. But your clinical experience very well noted. Bhavesh Bhai or Dr. Lalit, in your clinical practice, secretory carcinoma, have you seen?
Rare of
seen
the
only
rare.
one patient indeed.
Only one patient. If Dr. Lalit has seen only one patient, Bhavesh Bhai, where you and I will see.
Bhavesh Bhai might have seen much more.
So the point was, in this rarest of rare tumors, if it comes to you, the most common mutation is ETV6 NTRK3. NTRK1, 2, 3 is almost compulsory now in every NCCN guidelines, and larotrectinib has a very phase 2 promising data, so which is there. Again, chemotherapy has been tried, does not work, so it is still not recommended. And this would be my last slide. I have 2 more minutes left. So I would request all the panelists to talk about this rare head and neck cancer. What is your takeaway in 30 seconds, starting from Bhavesh Bhai?
For the all salivary gland or rare head and neck cancer, being a good clinician, at least read the book, at least go for clinical trials, go for at least now, not at present, still in 22 January, we should not go for immunotherapy. Let us find out some targetable, if you found, like HER2 and androgen receptors. Otherwise, talk in such type of good panel discussion.
Dr. Lalit.
No, I think I agree with Bhavesh Bhai that we learned, in fact, a lot of new things today only. So androgen receptor, HER2, NTRK, these remains important target for us. And it is not that bad, in fact, if we test them and treat them properly.
Correct.
Only thing is NTRK testing is again challenging. In fact,
Correct.
I had one patient where it was negative. So I'm not very sure that how good or bad we are testing the NTRK.
It is 2 to 3%, and I have been testing regularly by Lalit sir. I have not found a single NTRK positive as yet. Amol, your closing remarks?
Now, what is the most important thing is that these are the rare tumors in which we must do NGS for all cases that happen to come to us. That is the only important thing.
I completely agree on that. Dr. Shiva Kumar and then Dr. Arvind.
I second the point that was made that in these tumors, NGS has to be made, and we should encourage these patients to participate in whatever clinical trials that are available.
Just to add on to what both of you talked about NGS, I think HER2/neu can be done by IHC also, and we should not just wait for NGS report.
Yes,
that is what I mean. Dr. Arvind.
By NGS is to identify any new targets as well.
At that point, very well taken. Arvind, last point, and then I hand it over to Dr. Jyoti.
IHC followed by NGS, sir.
IHC followed by NGS. Okay. I think as Dr. Lalit said, after reading and after this panel, one good thing which I learned is, these rare tumors are not so bad if they are treated properly. With that, I close. Dr. Jyoti.